Hello, today's review is on sulfonylureas. Back in 1942, a researcher called Jean Bon and his colleagues noticed that some sulfonamides caused hypoglycemia in experimental animals. This accidental discovery led to the first clinically used sulfonylurea, a drug called carbutamide, but it was withdrawn from the market because it adversely affected bone marrow. However, this paved the way for the synthesis of first and second generation sulfonylureas. The first generation sulfonylureas include tolbutamide, acetohexamide, tolazamide, and chlorpropamide. These are no longer being used because they have a higher prevalence of hypoglycemia and risk of causing a cardiovascular event compared to second generation sulfonylureas. Second generation sulfonylureas include glyburide, glipizide, glimepiride, and glycoside. Glycoside is not available in the US, so we will discuss the three second generation sulfonylureas that are available in the US. Now let's get into the pharmacology of sulfonylureas. Sulfonylureas are what we call secretagogues. They exert their therapeutic effect by binding to receptors on the pancreatic beta cells that stimulate the release of insulin. Before initiating a sulfonylurea, you should order a C-peptide test to see if the patient is still producing insulin. Proinsulin, which is made in the pancreas, is the precursor for insulin. It is a molecular chain containing C-peptide and insulin. When the C-peptide is cleaved off, then insulin remains. The amount of C-peptide is directly proportional to the amount of insulin, which makes the C-peptide test a great predictor of endogenous insulin production. Sulfonylureas are indicated for type 2 diabetes as monotherapy or adjunctive therapy. However, they are contraindicated in patients with type 1 diabetes. Sulfonylureas may be ineffective due to primary failure or secondary failure. Primary failure is when the patient fails to have an initial therapeutic response to the sulfonylurea, while secondary failure occurs with disease progression or with chronic use of sulfonylureas. It is believed that chronic use causes the downregulation of the pancreatic beta receptors to which sulfonylureas bind. With fewer receptors available, sulfonylureas lose their efficacy. So when the pancreas stops producing insulin and the patient starts receiving exogenous insulin, the sulfonylurea should be discontinued. Now let's discuss the pharmacokinetics. The second generation sulfonylureas have distinct pharmacokinetic profiles. However, they are all absorbed from the gastrointestinal tract and food delays their absorption. They have different onsets of action, half-lives, and duration of action. This is important to know because these can help you determine which sulfonylurea is right for your patient. For instance, the onset of action of glyburide occurs within 1 hour. It has a half-life of about 10 hours and its duration of action is roughly 24 hours. This would not be a good choice for someone who is predisposed to hypoglycemia, such as patients with hepatic or renal disease. However, glimepiride exerts its effects within 1 hour with peak effect in 2 to 3 hours. It has a half-life of about 5 to 9 hours and lasts about 24 hours, whereas glipizide has a shorter half-life than glyburide and glimepiride. Its half-life is 2 to 4 hours and it lasts about 12 to 24 hours. This is an excellent option for patients who are hepatically and renally impaired. All sulfonylureas are metabolized in the liver, but glyburide and glimepiride both have active metabolites, while glipizide has no active metabolites. Active metabolites, if they are strong enough, may prolong the hypoglycemic effect of the sulfonylurea. So knowing the pharmacokinetic profile can help you to decide which sulfonylurea is best for your patient. All three sulfonylureas are excreted in the urine and feces. Sulfonylureas are usually dosed once daily or twice daily and are given 30 minutes before a meal. They have many benefits that include that they're inexpensive and they're effective. They yield about a 1.5 percentage point decrease in A1C. But they also have a few side effects. The main side effects are weight gain and hypoglycemia. They can also increase the risk of having a cardiovascular event. Other side effects include hemolytic anemia, which can occur in patients with glucose 6-phosphate dehydrogenase deficiency. Therefore, sulfonylureas should not be given to patients with this condition. So, just to recap, there are 3 sulfonylureas available for use in the United States. They are indicated for type 2 diabetes. They work by secreting insulin from the pancreas. Based on their pharmacokinetic profile, glipizide is the least likely of the 3 to cause hypoglycemia because it's the shortest acting of the 3 sulfonylureas. The benefits include efficacy and cost effectiveness. The primary side effects are weight gain and hypoglycemia. They may also cause cardiovascular events or should I say increase the risk of cardiovascular events, and they may also cause hemolytic anemia. So they should be avoided in patients at risk for this condition. This concludes our review of sulfonylureas. Until next time, have a good one. Thank you.